welcome back to The Explainer. Today, we're tackling an absolute giant in respiratory medicine, chronic obstructive pulmonary disease, or COPD. We've combed through the latest source data to bring you a sharp, high-yield breakdown. No fluff, just the facts. So let's map this out together. Okay, let's dive right into this. The core definition of COPD, it centers on a persistent, progressive airflow limitation. And that word, progressive, that is absolutely crucial here. We aren't just talking about a temporary, asthma-like wheeze. The data clearly points to permanent structural breakdown. The airflow is restricted because of this nasty combo of small airway disease and actual parenchymal destruction in the lungs, and it just keeps getting worse over time. Here's our clinical roadmap for today's explainer. First, etiology and clinical features. Second, diagnostic investigations. Third, the GOLD 2025 treatment plan. And finally, managing acute exacerbations.
Section 1. Etiology and clinical features.
Now, this brilliantly illustrates a really crucial contrast when we look at what's actually causing the structural damage. On one side, tobacco smoking is the absolute heavyweight. We're talking over 90% of cases in high-income countries. But you've got to watch out for this notorious curveball, alpha-1 antitrypsin deficiency. It's a fascinating genetic exception that causes early-onset basilar emphysema. It is a massive reminder to always look beyond a typical smoking history, especially if your patient's age just doesn't fit the usual profile.
Of course, while tobacco dominates, the sources emphasize that we literally cannot ignore the other factors. For example, prolonged exposure to biomass fuel. That's actually a huge driver of COPD in many parts of the world. Then you've got occupational dusts, harsh chemicals, and broader familial genetics playing massive roles too. It really proves that digging into a patient's environmental and workplace history is just as vital as asking if they smoke.
So how does this actually present on the wards? Well, the absolute hallmark symptom is progressive dyspnea. It's this shortness of breath that relentlessly worsens over the years. You'll frequently see this paired with a chronic cough, usually bringing up sputum in the mornings, right alongside a noticeable wheeze. Physically, you're looking for that classic barrel chest, hyperresonance when you're percussing the lungs, and distinctively reduced breath sounds. You'll often spot these patients relying heavily on pursed-lip breathing and using their accessory muscles just to force air out of those damaged lungs.
And things can get dangerous quickly. If left unchecked, the disease progresses into some really severe end-stage complications. We're talking major systemic risks like cor pulmonale, which is right-sided heart failure brought on by the damaged lungs. There's also an elevated risk for a sudden pneumothorax and profound systemic weight loss as the patient's body literally exhausts itself from the sheer caloric effort of just trying to breathe.
Moving on to Section 2, Diagnostic Investigations. When it comes to objective medical confirmation, everything in the guidelines hinges on one specific, glowing high-yield number, less than 0.70. A post-bronchodilator FEV1 over FVC ratio below this exact number is absolutely mandatory to confirm airway obstruction. Honestly, without this specific spirometry result, the data states you simply cannot make an official COPD diagnosis. Now, what's really interesting about this data is how rigidly the disease severity is stratified once that obstruction is actually confirmed. It's based entirely on the FEV1 percentage predicted, forming this precise four-step evidence-based ladder. You start at GOLD 1 for an FEV1 of 80% or higher, drop down through GOLD 2 and 3, and hit the absolute most severe stage, GOLD 4, for anything less than 30%.
But hey, spirometry isn't your only diagnostic tool. Chest x-rays are incredibly useful for visualizing hyperinflation and those large air pockets we call BLE. The guidelines also make it super clear exactly when to trigger an arterial blood gas. Do it if the FEV1 drops below 35%, or if you're seeing clear clinical signs of respiratory failure. Oh, and remember that genetic curveball from earlier? Alpha-1 testing is highly recommended if your patient has an unusually early onset of the disease.
Section 3. The GOLD 2025 treatment plan.
Our tactical defense is built entirely on the latest GOLD 2025 protocols, and the absolute foundation here is the assessment framework. It's this incredibly elegant analytical approach where your whole treatment strategy relies on combining just two key factors. You assess the patient's daily symptom burden, and you evaluate their specific risk for future exacerbations. You literally have to measure both to establish the right therapeutic path.
So the crucial point is, smoking cessation is the single most effective intervention. Period.
It's so easy to get totally lost in the weeds of pharmacology, but combining inhaler therapies with active counseling to help a patient quit smoking, that is fundamentally the greatest step you can take to slow down the structural destruction of their lungs. It saves the most lives, for sure.
Okay, let's carefully walk through this crucial treatment table. You start simple for Group A. That's the low-risk, low-symptom group, with either a short-acting beta agonist, SABA, or a long-acting muscarinic antagonist, a LAMA. Group B requires stepping it up to dual therapy, combining a LABA with a LAMA. But Group E, your frequent exacerbators, is where the protocol gets highly specific. We use triple therapy here, so that's adding an inhaled corticosteroid, or ICS, to the LABA and LAMA, but only if their blood eosinophil count is 300 per microliter or higher. That eosinophil threshold is literally the major deciding factor for adding the steroid.
Beyond the inhalers, you've got some absolutely vital supportive therapies. Vaccines for influenza, pneumococcal, and COVID-19 are essential to prevent flare-ups. Then you have pulmonary rehabilitation, which is backed by robust, grade A evidence. And for the most severe cases, long-term oxygen therapy, or LTOT, is indicated for 15 hours a day. But you strictly use this if they meet specific parameters: a PaO2 of 55 millimeters of mercury or less, or an SpO2 of 88% or lower.
Let's move to Section 4 and see how this builds. Managing acute exacerbations.
First off, we've got to clearly define the clinical trigger for an exacerbation, because this dictates immediate changes in patient management on the wards. The data states that an exacerbation is marked by a sudden increase in dyspnea, coupled with either an increase in sputum volume or an increase in sputum purulence. When a patient crosses that line, you have to act fast.
So here is your acute rescue protocol. It kicks off with a nebulized short-acting bronchodilator, a SABA with or without a LABA, just to rapidly open up those airways. Next, you hit them with a very specific course of systemic steroids, particularly prednisolone at 40 milligrams for exactly 5 days. And here's an interesting caveat. The guidelines stress that antibiotics should absolutely not be handed out automatically. They are only introduced into the mix if purulent sputum is actually present. Which brings us to a final provocative thought. Knowing that COPD is persistently progressive, how can strict adherence to these exact Goal 2025 protocols fundamentally alter a patient's inevitable trajectory? Sure, it's a permanent structural disease, but with this kind of precise, targeted management, you have immense power to improve their quality of life and actively put the brakes on that progression. Thanks for exploring this with us today on The Explainer, and we'll see you next time.